The following podcast is part of a certified educational activity titled Candid Conversations in Lupus, Navigating Advances in Diagnosis and Treatment to Provide Optimal Care for Each Patient. Access the entire activity and complete the post-test at peerview.com/YHV860. Downloadable slides and practice aids are also available.
I'm Dr. Ken Kalunian, a professor of medicine in the Division of Rheumatology, Allergy, and Immunology at the University of California, San Diego School of Medicine in La Jolla, California. Welcome to this educational activity on addressing unmet needs in patients with lupus. Before introducing our guests, I want to provide a quick overview of the current state of affairs when it comes to lupus management for our internal medicine audience. So let's get started. Systemic lupus erythematosus, or lupus, is a complex heterogeneous autoimmune disease with enormous impact, disparities in outcomes, and increased mortality. While lupus impacts people of all ages and races, it most often threatens the health of young women who are often of non-Caucasian ethnicity and of low socioeconomic status. Among chronic inflammatory diseases in young women aged 15 to 24 years, it is a leading cause of death, with higher rates of death than diabetes mellitus or HIV. The prevalence of lupus is on the rise globally, and mortality rates from lupus remain 3 times as high as the general population. While lupus mortality rates declined for the last few decades of the 1990s, they've been stagnant since, and enormous health disparities persist among adult and childhood lupus populations. Racial ethnic groups, including African Americans, Hispanics, and Asians, have significantly higher risk of death due to lupus, and geographical differences, poverty, and education levels, and insurance status all have a high impact on lupus mortality. There is notable impact on work, finances, and other socioeconomic disparities associated with lupus. Not surprisingly, numerous healthcare access issues also exist, including access to specialty care and hospitals skilled in treating lupus. Such inequalities contribute to the significant unmet need in the care of people with lupus. In contrast to other autoimmune diseases such as rheumatoid arthritis and psoriasis, approved medications for lupus remain very limited. Only one treatment, Belimumab, has received regulatory approvals in the last 60 years. The field has long struggled with establishing a clear pathway for lupus drug development, given persistent challenges in understanding the biology of the disease, defining clinical trial entry criteria and endpoints, developing instruments to measure changes in clinical activity, and controlling background medications. There have been repeated failures over the years to demonstrate superior drug efficacy compared with the standard of care, but optimistically, a number of other therapeutic approaches are under investigation in lupus. These include B-cell targeted therapy, anti-JAK or STAT or tyrosine kinase approaches, and interferon alpha inhibitors such as anifrolumab. Another consideration is safety. Some of the current treatments used for lupus, including glucocorticosteroids and immunosuppressive treatments, are associated with significant toxicity and poor long-term outcomes. Today's program is going to take a closer look at challenges associated with the management of lupus and explore why poor outcomes, high societal burden, and excess mortality are common in this population. At the end of the activity, I hope you are able to look at these challenges more as opportunities and are able to integrate recent advances into patient care strategies in order to facilitate progress towards more timely diagnoses, important treatment options for short-term and long-term outcomes, and appropriate access to care. With that, I'd like to introduce my 2 guests tonight who will lend their expertise to a discussion of best practices to improve the care of patients with lupus. Joining me tonight is Dr. Joan Merrill from the Oklahoma Medical Research Foundation, the Lupus Foundation of America, and the University of Oklahoma Health Sciences Center in Oklahoma City, Oklahoma, and Dr. Maureen McMahon from the David Geffen School of Medicine at UCLA in Los Angeles, California. Thank you both for joining me tonight.
Thanks for having us, Ken.
Good to see you guys. So let's dive right in and discuss the clinical manifestations of lupus. What clinical pearls, Maureen, would you share with our internal medicine colleagues when it comes to recognizing the signs and symptoms of lupus?
Well, I think that lupus can be such a tricky disease to recognize because it can have so many different manifestations. So, lupus can involve almost any organ in the body. But I think that some of the things that I look for when I'm evaluating a new patient for a possible diagnosis of lupus are things like constitutional symptoms. Those are seen in so many patients. One of the most common symptoms that we see is fatigue. We also look for fevers, any muscle aches, and any weight change, and in particular, unexplained weight loss. In addition, lupus patients can have arthritis and arthralgias, and that arthritis tends to be an inflammatory type arthritis. They can have mucocutaneous involvement, including skin rashes. And when I think about the skin rashes associated with lupus, I think particularly of any rashes that get worse when exposed to the sun. In addition, I think about ulcers in the nose or in the mouth. Cardiac involvement can also be common, so we look for any evidence of cardiac disease. Also, Raynaud's phenomenon is often associated with lupus as well. And certainly more severe manifestations such as vasculitis or any thromboembolic disease. We always want to think about the kidneys being involved, and so I'll often look for proteinuria or any red or white cells on a urinalysis. Patients can also present with gastrointestinal involvement. Pulmonary involvement can also occur. And again, I think particularly about serositis associated with pleuritic type symptoms. Neuropsychiatric involvement can also occur. And when we think about the most severe manifestations of neuropsychiatric involvement, we think about seizures or psychosis. We also look for hematologic abnormalities, such as low white counts, anemia, particularly hemolytic anemia or thrombocytopenia. In addition, patients can have ophthalmologic involvement as well.
Great. That's very thorough. When I'm on the wards, I am often baffled by the number of residents and medical students, who sit in front of me with the classification criteria for lupus and check off the boxes. Is that the right approach for diagnostic purposes? What do you think about that? What do you tell the medical students? I have my own preferences, but I'd like to hear what you do.
Yeah, I mean, I think that the classification criteria are helpful as a way to start. But a couple things I always mention to students, a lot of times they'll say, well, the patient had a rash before, but they don't have a rash now, so it can't be lupus. And so one of the things I always want to tell them is that, these things can accumulate over time. They don't all have to occur at the same time. I also think that there are a number of manifestations that we want to think about that aren't on the classification criteria. So we think about the classification criteria as being a way to really identify patients with lupus for clinical trials, so that we can all agree that the patients have lupus. But there are so many symptoms that patients can have that don't actually fit into that classification criteria very strictly.
So Maureen, it sounds like you're taking the artistic approach rather than the scientific approach for diagnosing lupus, which is pretty much what I do. I think that we're all awaiting the onset of other types of molecular or maybe biomarkers for helping us in the diagnosis of lupus, or some other schemata that we need to perhaps utilize to replace that artistic approach. Or maybe the artistic approach is always going to be the best. I'm not quite sure. Joan, would you like to comment on the use of some preliminary attempts at making the diagnosis through biological and biomarker type approaches?
Yeah. Well, accessible to everybody for a very long time have been panels of autoantibodies that are quite characteristic of lupus. one of the issues that we have with all of these lists of things that people can get that mimic lupus is that almost all of them could be a different disease if they're taken all by themselves. So we have fibromyalgia, which can cause a lot of pain in the muscles and a lot of fatigue, which is very hard to differentiate from a lupus patient flaring. So you wait and you watch just a little bit to be sure that there is an inflammatory disease with some more features that are more specific to lupus. The commonest presenting features of lupus are arthritis and rash. So that's what you're most likely going to encounter to raise your suspicions higher. At that point, when you see a characteristic lupus rash, and we can probably get back and discuss what those look like in a little while, when you see something like that, or when you see an inflammatory arthritis, then you might be sending a panel of autoantibodies. So if a patient has rheumatoid factor and anti-CCP antibodies, you start to think about rheumatoid arthritis, but in a younger woman who might be African American, you might think, well, you know what? I can see that in lupus as well. So you're going to extend your panel just a little bit. Lupus patients usually have a positive ANA. They don't always have it every time you test it, but if you try a few times, you're going to find a positive ANA. The exception to this are people who have antibodies to anti-Ro. If you have a patient with antibodies to anti-Ro and you don't have a positive ANA, a lot of us will interpret that as, well, it's a kind of an ANA. And if it's associated with features of lupus, we'll generally make the diagnosis without the ANA at that time. But that's relatively rare. So, in common practice, you're going to see a positive ANA. Now, you can see a positive ANA in lots of other diseases, and a lot of minority patients will have a positive ANA if they have rheumatoid arthritis or, or a chronic liver inflammation and all kinds of other things. In fact, there's been a lot of literature about ANAs appearing in people during infection. So, you're not going to stop there. You're going to kind of expand that a little bit. You become extremely confident about that if you see an antibody to double-stranded DNA. Also, anti-SM or anti-Smith antibody tends to be very specific for diagnosis of lupus. If you put together a combination of a few of the less specific antibodies, but they're starting to mount up, you're also going to have a high suspicion for lupus. So ANA plus anti-Ro plus anti-cardiolipin antibodies, they don't prove lupus, but you begin to really suspect that might be a lupus patient. And so you add that together with at least one of the common features, such as the classic lupus rash or arthritis, and then it's probably time to send that patient to a rheumatologist.
Good. That was very nice. Let me just follow up on that, Joan, a little bit. We often have patients referred to us in our rheumatology practices for a whole host of different reasons in the setting of a positive ANA, which sometimes is prudent and sometimes really isn't. How can we advise our internal medicine colleagues on how to best sort of understand when it's appropriate to order an ANA and when, in the setting of a positive ANA, it's appropriate to refer the patient to us as rheumatologists?
It's a really good point, really good point. I want to follow up on something Maureen said that was absolutely correct. Fatigue is the commonest symptom that you see in lupus. That is what the patients will be most concerned by for the most amount of time during the course of their illness, which can last, for a lifetime. So fatigue is extremely common in lupus, but fatigue alone with a positive ANA is highly unlikely to be lupus. So you really want to see a more specific symptom before you even order the ANA. And again, inflammatory arthritis and rash will be, and I think we should get back and talk about what lupus rashes look like. But if you see a rash that looks like lupus, and it doesn't go away in 2 days and never come back, if it's recurring a bit, if you see the polyarticular arthritis, then you're going to start ordering labs. Now, when does it become really important to order labs? That's when a person gets sick. So if you see in a urinalysis a high test for dipstick protein, I would say that that at that point in a young person who doesn't have a urinary tract infection, once you've ruled out, or it's not a person with severe diabetes or has been taking cocaine, and there are other reasons to have protein in the kidney. And if you see it's a young woman, it's a young minority woman, you are going to then send the autoantibodies and ask for a rheumatology consultation.
When a patient is referred to you, just so that we're clear, and both of you have hit on this quite well, but just to make it clear, when we as rheumatologists see a patient with suspected lupus, and we actually agree that it is in fact lupus, what lab tests do we generally obtain at that point? What do you usually obtain?
So the first time I see a new lupus patient, if I only have an ANA test, I will look for other antibodies that are maybe more specifically associated with lupus. So I'll check a anti-double-stranded DNA, I'll check an SSA and SSB, I'll look for anti-Smith or RMP antibodies, and I'll look for antiphospholipid antibodies. Now, once I have those tests, there's only a few of those tests that I follow, and I'll talk about that in just a moment. But every visit for every patient, I check a complete blood count. If there's any anemia present, then I will check for a direct Coombs test to look for any evidence of hemolysis. Every visit, I'll check a comprehensive metabolic panel. I do check erythrocyte sedimentation rate, or ESR, at every visit. I don't necessarily check a CRP at every visit, but I do think it's helpful, especially in an initial evaluation, to see if there's increased inflammation. Every visit, I'll check a urinalysis, and if there's any suggestion of protein, as Joan mentioned, then I will check for spot protein creatinine ratio to get a better estimate of the level of proteinuria. And then finally, the tests that I check every visit include the double-stranded DNA antibody, because we know that those titers can go up with flares or sometimes preceding flares. And in addition, I'll check the complement levels, the C3 and the C4, because those can lower in association with disease activity. And then finally, if I have a patient who has any other specific symptoms, say for instance, if they have muscle weakness, then I'll check things like a CK.
Great. In terms of predicting future events in lupus patients, you want to talk a little bit about what you screen for initially and how often you look? And I'm talking about things like recurrent fetal loss, thrombotic events, and cardiac events, things like that.
So to check for things like future risk for thrombosis, I'll check antiphospholipid antibodies, including the anticardiolipin antibodies, also the beta-2 glycoprotein-1 antibodies, and in addition, looking for some form of lupus anticoagulant, and the one that we check here at UCLA is the DRVVT. And we know that when patients have those antibodies, it may put them at risk for future thrombosis. And those are also important when a patient is looking to have a pregnancy, because they can predispose to fetal loss. Also, when a patient is planning a pregnancy, I'll also check for an SSA antibody or the Rho antibody, because we do know that that can be associated with neonatal lupus and with a risk of heart block. So those are important to know in a patient before they plan pregnancy, because it requires some increased fetal monitoring throughout pregnancy.
Great. Joan, did you have anything to add to that approach?
I would add that anti-Rho antibodies are also associated very strongly with subacute cutaneous rashes and lymphopenia. And although those are not as life-threatening as some of the things that Maureen was talking about, they can be very devastating to a patient in a southern climate during the summer, and can be quite horrible to have. I'm talking about the subacute cutaneous rash. And so that patient can be warned in advance to watch for sun exposure and try to protect the skin. So antibodies to double-stranded DNA are the most strongly associated with nephritis, and a predictor of nephritis can be a combination of the DNA antibody going up and the complement being consumed, and therefore the complement factors C3 and C4 start to go down. You see that, you're going to start maybe seeing the patient a little more often to test and make sure they're not developing proteinuria. But also there's some literature that anti-Rho antibodies are associated with worse prognosis in nephritis. And what that might really boil down to, if we take a step back from the scheme of things, is that the more autoantibodies you have and the more immunologic activity that you have, it just may be a worse prognostic factor for everything. And finally, we are about to have available in the clinic tests for a little bit of a more sophisticated biomarker, which is activation of the type 1 interferon system. And so there's several companies now working on getting those tests out, and hopefully in the near future we can use those. This generally gives us a somewhat sicker subset of lupus patients, more likely to develop nephritis, more likely to have more autoantibodies, and is also found to be a little bit more common in non-Caucasian populations. Although one thing I do want to say is that we can't really think about patients by race. It's a very primitive way of thinking about genetics. So the sickest lupus patient in the world could be from any race, and a very mild lupus case could be in any race. When we talk about race, it's just because that's the best genetics that we have available to us in the last 30 years of epidemiologic studies. But in the future, I think we're going to do better, and we're going to be able to define patients a little bit more by who this individual is and what's going on in this individual person.
That was great. I want to focus on two areas of lupus that I think are worth pointing out to internal medicine, an internal medicine audience. Things that they probably don't hear as often as they may perhaps need to, being at the forefront of the patient's care. Maureen, could you talk a little bit about your work on the cardiovascular risk factors and predictors of those risks?
Yeah, absolutely. So, as you both mentioned, we know that there's an increased risk for cardiovascular disease in patients with lupus. It's anywhere from 2 to 10-fold increased risk compared to the general population, even after you take into account all of those traditional Framingham risk factors that we think of. And to me, what's most striking is when you look at a young lupus population and compare them to their age-matched counterparts, the 35 to 44-year-old population, those women might have up to a 50-fold increased risk of having a heart attack compared to an age-matched woman who doesn't have lupus. So, again, I think it's so important for primary care doctors to be aware of this increased risk. And in particular, to think about it in patients who you wouldn't typically really look for atherosclerotic cardiovascular disease. So even a 35-year-old patient can come in complaining of typical chest pain, and really it is important to think about that as a risk factor. So right now, we're still really looking for specific treatments for patients to prevent this atherosclerotic risk factor. Our group is looking for biomarkers that might help us identify these patients. But until those are really widely available, I think what we really need to do is focus on preventing what we know works in the general population. So a couple of things to think about with patients, when we go and we use some of the normal risk calculators that you would use to determine targets for lipid levels or targets for blood pressure. There have been a lot of groups that have suggested that it's important to think of lupus as a diabetic equivalent. So, really use that as those patients, think of them as being in the highest category for targeting therapy. And of course, it's important in patients to modify any of these risk factors that we can. So certainly, encourage patients to stop smoking if they're still smoking, control blood pressure, control, lipid levels, particularly in patients who have nephritis. We know that patients who have kidney involvement with their lupus are at the highest risk for having cardiovascular events. And so remembering to treat things like their lipids is always important.
Great. Joan, can I ask you a question? You brought this topic up about a couple of times about skin. Yeah, let me pose this question to you. Is cutaneous lupus erythematosus a separate disease, or is it sort of an overlap in some patients with systemic lupus. What's the thinking there?
Well, what we do know is that pathologically, the types of cutaneous lupus are found in people who meet all of these various criteria for systemic lupus, and also in people who do not, who just have skin involved. Pathologically, you cannot tell them apart. So I think we have to think of lupus as a continuum. Other manifestations of lupus are that way also, if you think about it. People with antiphospholipid antibodies don't have to have lupus. They may have no other autoimmune disease but the antiphospholipid syndrome, and yet people with SLE can have the antiphospholipid syndrome. Thrombocytopenia or complement-mediated thrombomicroangiopathies, which are life-threatening and just about the worst manifestation you can see in lupus, can occur without lupus. It occurs in a number of disorders and also genetic disorders. So lupus is a continuum of features. We don't really understand why some people get affected in one part of their body and others in other parts of their bodies. And the biomarker tools that we have today are inching along and making some progress in being able to sort these things out and being able to predict, which person falls in which category. But remember that lupus is a dynamic situation. We know clinically it ebbs and it flows. And it may very well be that there are disease triggers or anything that can activate the immune system. And then a person is kind of genetically ordained so that when things tip over and they can't quite manage that immunologic event, it turns into this disease that we call lupus. So to get back to your question, which I've strayed a little bit from, no, skin disease that does not have the other components of systemic lupus is the same thing as the skin disease that we see in lupus. But we do have to get back sometime to describing what those clinical manifestations are, because that's important for primary care physicians to be able to differentiate from other kinds of rashes.
As a rheumatologist giving advice, and this may be a biased answer, to an internal medicine audience, how would you recommend that they sort of triage their patients in terms of whether a particular patient needs to go to a rheumatologist or a dermatologist? I mean, at my institution, at UCSD, we have a joint clinic staffed by a rheumatologist and a dermatologist, and so that's easy. But that model doesn't exist in very many places. So in most cases,
I think a joint clinic is a really wonderful thing. And I think what this really is going to get us to is the theme of joint care of patients. It may be that I, as a rheumatologist, may need some help from a dermatologist if I'm unsure about a rash. I'm not sure if that's a lupus rash or from something else. And, they can help me with some of the more refined ways of looking at rashes, including interpreting biopsies that often come back a little bit, not specifically being able to make the diagnosis, but having some features that seem like it could be lupus. And they can help us with a differential diagnosis in that situation. But a dermatologist is, especially in a busy clinic where they're taking 5 minutes per patient and then biopsying them and then reading the biopsy results and then prescribing good medicine. But they may not be looking for all the other features of lupus that a rheumatologist is. So in our clinic, which is not a joint dermatology clinic, and we're sorry it isn't, we're always very careful to not just assume a person has only skin lupus, even though that may be the complaint that brought them in. And we will do a workup on those patients. So I think as an internal medicine doctor, the thing to try to recognize is whether you should suspect a lupus rash. Now, interestingly, lupus rashes aren't as much more common in young women of childbearing years. You can see them in men. You can see them in older people. So you're going to be a little bit more expanded when you think about, could this be lupus? But we have a pretty simple way of covering most, not all, but most lupus rashes. And that's to divide it up into acute, chronic, and subacute. So acute cutaneous lupus is usually seen as a malar rash, meaning it goes across the bridge of the nose and onto the cheeks and usually spares the nasolabial folds. And Often in younger patients who have systemic lupus, it'll start to get worse right around the time they're going to have a big flare. So that's a little pearl, and you might want to really take that quite seriously, even if it doesn't look very bad. And it's usually raised and red and doesn't tend to be scaly, can be light pink in some patients, but it's not a blush. It's not something transient that comes and go. One advice that's given to us by the people who developed the BILAG instrument is don't consider this, acute cutaneous lupus unless it's been there, for a while, a few days to a week at least. And then if it doesn't go away, then that's a little odd. That's not a blush and it's not really a sunburn. So then you can be a little more suspicious, especially if it spares the nasolabial folds. And then subacute cutaneous lupus can be all over the body, and it can range in appearance from being kind of like circular red lesions or pink lesions with clearing in the middle, all the way to looking a whole lot like psoriasis. And it kind of overlaps sometimes in pathology with what we call chronic cutaneous lupus. The key with subacute cutaneous lupus is that it tends to be very photosensitive. So a patient can go out in the sun for a very short time and be covered by this rash. And that would be a clue that that's a lupus rash. Chronic cutaneous lupus is very easy to diagnose without a biopsy. It's usually, sometimes it's discoid in shape, and that's why it's also called discoid lupus. It's deep, it's burning, it's scaly, it gets, there's hypertrophy, there's scarring. So once you've seen a classic case of discoid lupus, it's usually pretty easy to diagnose. Now, there are other types of lupus, cutaneous involvement. There's tumid lupus, paniculitis, and so there you might need more help from an expert, especially in a milder case of one of those things. But when you have a suspicion for a lupus rash, there's no harm in going to a dermatologist to confirm it. But depending on the dermatologist and who they work with and how they do their workups, you want to ensure that a good, proper, somebody's following that patient who would know whether or not this is someone likely to have systemic lupus and have other problems as well. Sorry.
Do you want to talk about the cutaneous treatment paradigm?
Yes, well, we do have some pretty potent topical agents that work on all types of lupus rash. Generally, acute cutaneous lupus does not need to be treated, although we will usually start a treatment called hydroxychloroquine, which you'll hear more of when we talk about general lupus treatment, because it's sort of like a drug we want to give to all of our patients with lupus, no matter what their manifestation is. But that would be given if there's acute cutaneous lupus. When you get to subacute cutaneous lupus, it can be harder to manage, and topical treatments aren't so great when it's covering large portions of the body, but you can use topical steroids, topical tacrolimus, and all sorts of compounds that have been made that may be somewhat useful. Then again, sometimes in really severe cases, we actually go to immune suppression. And so you can use all of the immune suppressants that we're going to talk about later, and I won't get into all of them now. But all have been shown more or less to be effective. When you get to chronic cutaneous lupus, you're going to need probably more intense therapy. And this can range, I mean, you're not going to avoid using the topicals, and you're not going to avoid using hydroxychloroquine. These can be helpful, but almost always you're going to need to do something a little more. Tacrolimus has been shown to be useful, and also TNF inhibitors have been used, and there's a little controversy there because TNF inhibitors are also associated with drug-induced lupus. But in a lupus patient, sometimes it can be very helpful, especially if there's polypharmacy there, to make sure you don't get drug-induced lupus. But sort of an interesting concept, because drug-induced lupus doesn't usually happen to real lupus patients. It happens to people who didn't have lupus and suddenly they took the drug. So it has been shown to be a little bit helpful. And then, of course, not surprisingly, since thalidomide also has some inhibition of the tumor necrosis factor pathways, thalidomide has been used very successfully in severe cases of discoid lupus. And it can be associated with neuropathy, but there's some related drugs that are under development now and also exist on the market that may be a little less likely to cause that and may turn out to be very helpful. But update at 11. We have to see the data on that.
Great, that was wonderful. Maureen, do you want to talk a little bit more about Plaquenil? And
yeah, hydroxychloroquine is really my staple drug for all of my lupus patients. And there's a number of reasons for that. It's a mild drug, has a few side effects that we'll talk about, but overall really well tolerated. But importantly, it's got many benefits for patients with lupus as well. So we know that patients who are on hydroxychloroquine are less likely to have flares of their disease. But for me, some of the effects that I think are even more important when I'm talking to patients about hydroxychloroquine are the effects that we know that it has in preventing damage. So there have been multiple different studies that show that when patients are on hydroxychloroquine, they're less likely to accumulate damage in the long run from their lupus, and that's any kind of damage. But we know from other studies that hydroxychloroquine use is associated with a decreased risk of thrombosis. There have been some studies that show that patients on hydroxychloroquine are less likely to develop diabetes. And in addition, when patients have lipid abnormalities, hydroxychloroquine can have some beneficial effects on lipids as well. And in fact, there are some data to show that patients on hydroxychloroquine are less likely to have cardiac events. So overall, all of those protective effects are really one of the reasons why we rheumatologists love to use hydroxychloroquine for our patients. And I really encourage all of my patients to be on it unless they have a side effect. So as for side effects, there are some things that are rare. Cardiac toxicity has been described, so that's something to keep in mind if patients are on it. But I think the thing that we think about the most with hydroxychloroquine is the risk for retinal toxicity. And there's some data that if you keep patients on doses of less than 5 milligrams per kilogram, that risk is less. But regardless, we really need to make sure that we're getting our patients who are on hydroxychloroquine screened by an ophthalmologist. And I have my patients go to see an ophthalmologist every year. And when they see the ophthalmologist, most ophthalmologists will know what to do for hydroxychloroquine screening, but they need to do testing in the visual fields. And most patients will also have screening using the OCT test that ophthalmologists can perform to look for any evidence of hydroxychloroquine retinopathy. One of the things that will come up on a suspicious OCT report would be a flying saucer sign, which would be an indication that there is some retinal damage from the hydroxychloroquine. But I tell my patients that as long as they're being monitored regularly, it's in general a very safe and a very effective medication.
Joan, do you want to talk about the COVID elephant in the room?
Well, I mean, everyone's very aware that there was a great deal of hype. And you can't, it's human nature to look for a solution when there's a very scary problem. And so I understand the hype. And I guess in my own mind, I was hoping it would be true. But there was this notion that hydroxychloroquine might save us all from COVID-19. Turned out not to be the case. But now there's sort of hype in the other direction that it's this very dangerous drug, and I'm afraid it'll scare all of our patients. But a certain amount of cardiac arrhythmia, which is a rare and known side effect of antimalarials, but quite a few patients in the hospital setting with COVID-19 were found to develop arrhythmias, and it was unbalanced in several studies. Comparing those who received hydroxychloroquine and those who didn't. Now, the flaw in all of this, even though it's a known but rare side effect of hydroxychloroquine, is that people who received hydroxychloroquine in a lot of these non-randomized studies tended to be older and sicker. And when you're old and you have multiple medical morbidity, and you already have heart problems, and you develop a serious life-threatening infection, with or without hydroxychloroquine, you may be more prone to arrhythmia, particularly since the polypharmacy was not balanced in these studies. So I'm not suggesting that we should not think cautiously about the possibility that hydroxychloroquine working alone or together with synergistic drugs may not be causing toxicity to the heart in that setting. But I think we need to be able to reassure our patients, those of us who've been taking care of them for so many years and have not been seeing such side effects, that there's more to it than just these hyperbolic reports that this is a very dangerous drug that causes massive cardiac problems.
John, I think that some of the studies or clinical practices in the COVID setting were using higher doses than we generally use in lupus.
Well, they did use higher doses. The patients were tending, at least in the beginning of this pandemic, to be quite a bit older and have multiple medical problems and heart problems. So it is a different clinical setting, of course. But basically, it wasn't balanced. Until you get into a situation where you can do a randomized clinical trial where the control group can get some kind of standard of care, which is impossible to do in this pandemic because there is no standard of care. So it's you have to be very cautious in how you interpret the results of these studies.
Thank you. That's great. Maureen, we've covered the skin in terms of treatment. Do you mind talking just a little bit about how we treat the joints?
Yeah, absolutely. So, in patients who have relatively mild disease and don't have any kidney involvement, I'll often just start with non-steroidal anti-inflammatories. And sometimes that will be enough, but many patients it's not. So then we, step up therapy. So in the short term, glucocorticoids can be helpful to help control joint disease. But if patients need to be on it longer than a couple of weeks, I start talking to them about some other type of therapy so that we can avoid long-term use of glucocorticoids. So for me, generally, my next steps for joint disease, if I'm not trying to treat a lot of other different manifestations, I'll use methotrexate in that situation, and that can be helpful for many patients. I'll also try medications like azathioprine if methotrexate isn't helpful. Sometimes we'll use some of the other medications we use in rheumatoid arthritis, like leflunomide. In addition, in some patients who you have other manifestations that you're trying to treat as well, I have used mycophenolate for those patients as well, mycophenolate mofetil. This is kind of our lupus armamentarium of different drugs that we use. And then there is one biologic medication that's approved for lupus right now, and that's Belimumab. And I've used that in patients as well.
Great. The one area we haven't talked about, Joan, is renal disease from a treatment perspective. Do you want to talk about that a little bit?
Well, renal disease can be the first sign of lupus and I think I want to mention health disparities here, because the classic patient who comes into the ER with full-blown class 4 nephritis and nephrotic range proteinuria, very, very sick, is usually a minority patient, usually young, usually someone who had no idea that they had anything wrong with them until their feet started to swell. And then, of course, didn't seek medical care right away because they are like me. They like to avoid doctors. So then they get sick and then they come to the ER. And that's a classic case that we get in our ER. When you have a patient who's just a little bit older and wiser, into your late 20s and early 30s, and has a doctor and is able to be kind of noticed if something's starting to go wrong, you don't see that so much, and they may come to our attention sooner, and we may be able to see the nephritis coming. We may be able to treat it earlier, and we know that if you start to treat nephritis earlier, you improve the prognosis quite a bit. So that's a health disparity, and we should be aware of that. So particularly if you have a young African-American female or male, because men get very bad nephritis, the few men that get lupus get very bad nephritis frequently, and there is a positive dipstick, and there is just no reason for that to be there. The only other two reasons that are likely would be cocaine use or a urinary tract infection, if those two things have been ruled out, you've got to start to think lupus, because other reasons would be quite a bit more rare. Then you want to get on top of that very fast and refer that patient quickly. Now, what do? We get a patient who we have a high suspicion has lupus nephritis. They have antibodies to double-stranded DNA. They have low complement. They are spilling a high dipstick. I would start that patient on steroids right away. I might even start MMF right away and get them a fast biopsy. But I wouldn't even wait days. I would start to treat, because we can always withdraw the treatment if we're wrong. The chances of us being wrong are very slim when it's a classic presentation. So we do treat nephritis early and aggressively. Now we have a set of guidelines that Maureen was the second author on the paper that I think they were published in 2012, and worked very hard with Dr. Beverhan on this. And we sort of have a kind of an algorithm that we can follow, although in the past few years, I think we've been dissatisfied with how well we're doing, and we tend to go towards the aggressive end a little bit faster. So your choices for treatment, first-line treatment, are mycophenolate or IV cyclophosphamide, and that can be given at a kind of a classic, somewhat higher dose. It's certainly not high by oncology standards, but it's high by lupus standards, which would be 1 gram per meter squared, which you sort of work your way up to that over a month or two. You give it once a month, you give it for 6 months, and then you go into a maintenance phase with either less cyclophosphamide, and most people don't do that. They'll switch to an oral agent at that point, or mycophenolate mofetil. Or you could start with mycophenolate mofetil, and then when you get to the 6 months, you might switch. Now, do we always wait 6 months? No, this is a bit of an art. So if the patient isn't doing well, we're certainly not going to go to a maintenance phase. What I would like to think that I do, I hope I do it as much as I possibly can. At 3 months, if you don't start to see some improvement, I think you need to add things. So one regimen that's been used recently around the world is a combination of mycophenolate and tacrolimus. And that seems to be more effective than either agent alone. There are other options. The biologic Rituximab, which failed in several clinical trials, has shown some efficacy in nephritis when used in combination with drugs like MMF or cyclophosphamide. B cells are an important target. Type 1 interferons are an important target for nephritis. We don't have a whole lot of proof of that, but we know that there's a lot of it going on, so it's probably going to be important. And a broad spectrum approach really is the standard of care at this time, because using one drug may help someone with milder nephritis, class 3 nephritis, some people with class 5 nephritis, but a broad spectrum approach is going to be much more important, at least in the near future, to really get a handle on this disease and get a better prognosis than we currently have for our patients.
How about calcium uric inhibitors?
Well, yeah,
Talk a little bit about
tacrolimus.
them.
And voclosporin has been tested recently.
No, beyond. No, one's in development, I meant.
Voclosporin is in development.
Yeah, you want to talk about that?
Voclosporin had a phase 3 trial that was successful after a phase 2 trial was successful, and it was added to MMF, and actually gave rather impressive results.
For induction, right?
For induction therapy, yeah.
Right.
Yeah. And recently, Belimumab also had some positive results in nephritis as well. Yeah.
Added to standard of care, yes.
Added to standard of care, right.
And the nice thing about Belimumab is that it's very well tolerated when it's added to standard of care. Some of our other biologics can be a little toxic and have, had 1 or 2 trials where things started to look a little scary. That never really happened to Belimumab. So I always think of it as something that's sitting there on the shelf that may just tip us over into doing a little better. It's a little more gentle on the patient and may be able to add efficacy to standard of care.
It's an interesting drug because I think maybe we miscalculated in the beginning its utility. based on the fact that it took a long time to work, right? So it takes, on the average 4 to 6 months to work. And so trying to use it in generalized lupus, where we're really anxious to get a response from skin and joints, we didn't really show that huge of an effect. But if you add it on to standard of care, and in situations where you actually have, you want to have a long-term effect, you're committing patients to long-term therapy for nephritis, for example, the maintenance of a complete response, it may actually make sense to use it in that type of a setting, or other situations where you're looking.
There's good data suggesting that it prevents flares as well.
Exactly.
So this may be the kind of treatment we want to use to put in place to keep people well. It's a little bit of a different concept in medicine than getting them out of trouble.
Exactly. That's exactly what I meant. Perfect. Perfectly
and
said.
I actually think that there's some interesting data. I'm always interested in preventing damage long term. And although it's not a perfect head-to-head trial, there's some data out of Murray Urewitz's group in Toronto where they looked at patients who were in the open label phase of the Belimumab for up to 10 years and compared that to patients in his cohort who are matched for disease severity. And in the patients in the Belimumab arm, there was less damage accrual over time. So I'd love to see more data like that long term to let us know if this is another thing that we can think of to really prevent damage over time.
So I think that we're moving into an era of drug development where we are looking for new agents that can do several things, and maybe not all by one drug. So maybe a class of drugs that get us out of trouble, get patients out of trouble, get their disease under control quickly, like we're seeing with prednisone. We obviously have a lot of enthusiasm for using drugs other than prednisone, but yet work quickly because of the side effects of prednisone, that is. But also drugs that can be used long-term to decrease the burden of the disease, to maintain the state that we've gotten them into by using drugs that work pretty quickly and getting them out of danger, and also from the perils of damage, preventing them from getting damaged, preventing them from having, future events that are associated with the disease, whether that be from a thrombotic basis or from a damage basis, maintaining renal function, preventing the need for renal replacement therapy, things like that. What do you think of that, Maureen? What targets are appealing to you for both the initiation of a response and maintenance of a response kind of phases?
Yeah, I think one of the pathways that we've really realized in the last 10 years or so that's really important in lupus is the interferon pathway. And there's a drug, anifrolumab, that has had some success in the phase 3 trials and is being evaluated right now by the FDA. But that's a class of a pathway that I think is really interesting to target in lupus because we know it's important in renal disease, as Joan mentioned. It's also a pathway that's very important in skin involvement as well. And of interest to me, there's been some implication that the interferon pathway may have implications for cardiovascular disease and cardiovascular events. So I'll be excited to see how those medications do if they come online for us.
Joan, did you have anything to add to that in terms of your
well, I would second the motion about the interferon pathway. Anifrolumab was very successful in its phase 2 trials, but in fact, there was another drug called Cifalimumab that also did pretty well in phase 2 trials and met its primary endpoint. So they're slightly different. Anifrolumab blocks the receptor for all of the type 1 interferons, and Cifalimumab was a interferon alpha blocker. It blocked a certain subtypes of interferon alpha. So both of them worked. And the company went on to develop anifrolumab because it seemed to have more dramatic differences. In phase 3, one of the trials met its primary endpoint and looks pretty good. The other trial didn't meet its primary endpoint, And it was realized that there was a technicality in the endpoints of that trial, which didn't actually make a whole lot of clinical sense. And that was that if you started taking nonsteroidal anti-inflammatory drugs for any reason, you became a non-responder. And when another analysis was done where those patients were not necessarily called non-responders, they were allowed to go back in the pool to see whether they responded or not. Although the primary endpoint wasn't met, a number of secondary endpoints were met. If you line up the two most common endpoints used in lupus trials that are accepted worldwide, which are the compound endpoint of SRI-4 and BICLA, then it was tested 6 times between the phase 2 and you had 3 BICLAs and 3 SRI-4s. So there were 6 possible ways to win or lose if you combine the phase 2 and the 2 phase 3 trials. And 5 out of the 6 times, the drug looked effective.
The nice aspect of focusing on interferon is that it's very high up in the immune pathway, right? So it affects not only the the innate immune system primarily, but also the adaptive immune system. Many other attempts that we've had at looking at drugs, for example, targeting B cells, have focused mostly on one aspect of the adaptive immune system. And I think that we're moving into an area where we're looking at other ways of doing so-called double hits or triple hits, where we look at not only just attacking B cells, but also other aspects of the adaptive and/or innate immune system that are turned on. So Maureen, this has been a great discussion, but I'm wondering what you think about the future in terms of where we're going from a therapeutic perspective. What are our goals? What do we want to achieve? And how do we want to get there?
Yeah. So, going back to something Joan said early on, lupus is a really heterogeneous disease. And I think that up to this point in time, what we've really been trying to do is, hit it with, one hammer when really we, may need to really have a lot of different tools to get at what's wrong with each individual patient. So, I think that I'm excited that we have so many new targets and that we know so much more about the pathophysiology of lupus so that we can target many different pathways. But I think that in the end, we'll find that, different patients have different pathways that are active. And so hopefully with improved biomarkers, we'll be able to determine which patients are active in which pathways and really come up with the right treatments to prevent damage and further disease flares for our patients. But, unfortunately, we're kind of talking about a lot of this pie in the sky, where I hope lupus will be in the hopefully near future. But as it is right now, we're kind of left with what we have, and we're really using glucocorticoids way too often. I know that even in my practice where I hate using steroids and I avoid them and try to get, my patients to be on the lowest dose possible or none. Even in my patients, I use far too many steroids because it's really what we have that works quickly. But I really hope for a future where we won't have to use those steroids nearly as often.
So what would it take to supplant the need for corticosteroids? What type of agent would that be? Would it be a quick-acting agent, a powerful agent, all of the above? And how do we find that?
Yeah, I think that's a good question. I think that's one of the most common reasons why I start patients on steroids, because it's really the only agent we have that doesn't take weeks to months to, many, many months to start to work. And so I think that if we can find an agent that can work, almost immediately or at least within a couple days, I think that in those circumstances we can really start to avoid using steroids. But I have patients who remain on steroids even after we have other treatments. And so I do think that our treatments to date have not been as good as we want them to be. And so, hopefully as we have better treatments in the future, patients will be able to get off steroids because their disease will be controlled. And steroids ultimately, again, coming back to the idea of damage, we know how much damage steroids can do. There have been some studies that have suggested that 80% of the damage, long-term damage we see in our lupus patients is from steroids, that, the treatment that we're trying to prevent damage in the first place. So again, I think, finding more effective therapies and quicker therapies will really be the key.
Right. Are there certain aspects of damage that we need to target first in terms of thinking about drug development ideas?
Yeah, well, of course, my interest is looking at prevention of cardiovascular disease. And so I hope that will be something that companies will look at, whether we can prevent some of these cardiovascular events, any kind of atherosclerotic damage over time. I think that would be wonderful. We know, especially in young patients, again, when they have, strokes or when they have cardiac events, it can be really devastating. So hopefully some of our newer therapies will target that as well. I think that, we know, again, with steroids, we have diabetes, and we have risk to bone health. And so hopefully when we can demonstrate therapies have effectiveness without causing that type of damage, I think that will be a real benefit.
Are we working in a vacuum, or should we be working with our colleagues in other disciplines, like, for example, osteoporosis experts, cardiology experts, diabetes experts, or are we just fine working alone?
Certainly one of the reasons I went into rheumatology is because I like that, diseases that we care for, like lupus, you still have to keep all of your internal medicine skills. But I think that ultimately we're always better off when we call on the expertise of our colleagues. As much as, I try to keep up on every literature that I can, cardiologists are going to know, the latest data on the best treatments. It's good to work with our colleagues in osteoporosis with all the new medicines that are coming out. They can always be helpful as well. So again, I always favor a multidisciplinary approach when taking care of our patients.
Maureen, in wrapping this up, I'm interested in your thoughts on really what we can kind of leave our internal medicine colleagues with in terms of really when to consider lupus in general, when to consider involving us as rheumatologists in helping them co-manage their patients. What other strategies that are there for us to sort of better communicate our thought processes with them, how to engage them in the care of their own patients? We certainly don't want to take over their management of the patients because, as you've pointed out, one of the reasons you went into rheumatology, and I did the same, was because it really was, required the need for a broad knowledge of internal medicine. We don't want to do that because we need their collaborative approach. So what advice can we give them? What can we do to make management of their patients better?
Yeah, absolutely. Well, I think as far as referral, which is one of the things that you mentioned, I think that, we went over a lot of the different signs and symptoms of lupus. I think that if you have any patient who's exhibiting those signs and you do find a positive ANA, that would be a great time to refer to a rheumatologist, just so we can give further input and help diagnose the patient and help get them on the path for treatment. But I know that one of the areas, even though I've mentioned a lot of things, a lot of areas of damage that we need to monitor for in our patients, cardiovascular disease. One of the things we haven't really touched on, we know that there's an increased risk of malignancies in patients with lupus, in most malignancies, particularly hematologic malignancies. Looking at all the different comorbidities that we can see with lupus, I think that where we really need the help of our primary care colleagues is in doing all the routine health maintenance. A lot of times my lupus patients will come to see me every 3 months or frequently And, we talk about their lupus. We don't have time to think about a lot of those other things that primary care doctors do so well. Blood pressure management, cholesterol management really are so important in these patients. So I always try to have a good line of communication between myself and primary care doctors. I know it's not always easy, but I think that having a good collaborative team or team providers, if there are other specialists involved, and good communication between everyone is really so critical.
Great, I think that's really helpful. One thing that we've done at UC San Diego is to sort of develop a lupus center of excellence, if you will. And what that really means is that we've developed several clinics that are multidisciplinary in approach. We have a renal room lupus clinic. We have a dermatology, rheumatology lupus clinic, and are thinking of also developing a bone clinic as well for lupus patients. But I think that actually makes it even harder to get in to see lupus patients because we spend more time with the patients and therefore have less time for new referrals. Short of trying to convince our internal medicine colleagues to pursue careers in rheumatology, which seems to be working, by the way. I think that rheumatology was the number 2 hardest subspecialty to get into the last 2 years in a row. But short of that, Joan, what can we do to sort of make the referral patterns better? Are we missing something? Is there something that we can be doing better?
We're missing relationships. So, modern medicine has gotten to be so, except for your multidisciplinary clinic, which sounds like heaven to me. But I think around the country, it's gotten so fractured. First of all, the whole doctor payment, the care standards are seeing so many patients a day. So, we say we don't have time to get to all these things that the internal medicine doctor will get to. Well, guess what, guys? Internal medicine doctor doesn't have time either. So we don't have enough time. And what usually suffers first is not the direct patient care, it's the communication between doctors. And then on top of that is all the process we have to go through with HIPAA. So I don't know what the solution is, but I'd like to see a whole lot more online interactive discussions between people who have sort of different approaches to care or different sort of cutouts of what aspect of the patient's disease they care for. But we got to work as a team because none of us have enough time. And maybe if all of us gave it a little bit of time, but we communicated, that would be the solution.
I think that's very wise, very wise. Do either of you have any parting words for our colleagues?
Well, I think just my parting thought is that lupus, it's been a long journey for us, for those of us who take care of lupus patients, because we know that lupus is such a complex and complicated disease. But again, I think that with some of the collaboration that we've been talking about between providers, and hopefully with the development of new treatments in the future, I think that we can all get to a point where we really are able to prevent any long-term damage or complications in our lupus patients.
I think that all of us have seen a dramatic change in the course of lupus in our careers. I remember when I was a fellow, patients died like all the time, and patients still die, but it's not as frequent. And certainly we have, most importantly, a lot of new drugs in development. I think the last time I counted, there were 72 drugs in development for lupus right now, which is incredible. When I started my career, there were 0. I think that that's very stimulating, very exciting, and I think has really brought the field a lot of fruit, and also put it in the forefront of a lot of people's minds. And I think that what that's done is really caused a lot of interactions with lots of different disciplines, but most importantly, primary care doctors, and we really lean on you as primary care doctors to help us co-manage these patients. We lean on you for referrals, but we also lean on you for your help and guidance. Joan, did you have any thoughts?
Yes, I would like to quote the father of the New York theater, the great Harold Clurman, who said, "I am a pessimist. I believe the human race will survive." And what I'm thinking of is that we don't prioritize, we don't organize, we don't really do things efficiently, we don't really have things set up for the best interests of our patients. I'm sorry to say that, but it's a fact. It's just the way our society is. But on the other hand, somehow we muddle through, and when we get in trouble, we have incredible ingenuity. And so I think little by little, it gets a little bit better. And I agree with you, Ken, over my career, I think our patients are doing better and surviving longer. So I am a pessimist too, and I think we're going to do better for lupus.
Great. Well, it's been a pleasure working with you and discussing all this, Maureen and Joan. And again, I appreciate the time that all you colleagues out there have spent listening to us, and hope you learned a lot from us. And we look forward to doing this again with a whole new group of ideas, thoughts, and hopefully treatments. Thank you very much.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/YHV860. This educational activity is supported by an educational grant from GlaxoSmithKline.